just joining in a couple of minutes. Dr. Rishi also.
So we are live.
Good evening and a warm welcome to the All India Ophthalmological Society International Ophthalmic Conclave. We welcome all of you. We welcome all the speakers. Thank you for joining us. This is the session on corneal ectasias, what's new in 2025. And I'm Dr. Tushar Grover. I'm the coordinator for this session. So without wasting any time, I'd like to invite the moderators for the session, Dr. Anu Malik and Dr. Manpreet Kaur, and I would request them to take over and start the session.
Good evening, everyone. I welcome you all to the 5th International Ophthalmic Conclave and to the session on corneal ectasias, what's new in 2025. So I extend a heartfelt welcome to our esteemed chairpersons for graciously accepting the responsibility of steering our discussions today. Our chairpersons for today's session are Dr. Samar Basak, Director Disha Eye Hospitals and Research, Kolkata, and President All India Ophthalmological Society. Dr. Farad Hafezi sir, Cataract and Refractive Surgeon and Ocular Cell Biologist, ELSA Institute, Switzerland. He's a pioneer and key opinion leader of corneal cross-linking. And Dr. Namrata Sharma ma'am, Cornea Cataract and Refractive Surgery Services at RP Center, AIMS. And Chairperson Scientific Committee, AIOS.
I think we can begin with the first speaker. Dr. Rajesh has joined. Sir, may I request you to start with your talk on intrastromal negative meniscus lenticule with cross-linking in keratoconus?
Can I have the second talk? Because I just joined in. I'll have to open my presentation and.
Sure, sir. Dr. Tariq, if you are ready, we can start with your big bubble DALK in keratoconus.
Yes, I am ready.
Okay, sir. So we'll start with your talk first. And it's big bubble DALK in keratoconus. Dr. Tariq, of course, needs no introduction. He's a pioneer in DALK. We have all seen his beautiful surgeries in which he can rescue the procedure from any complication. And it's always a pleasure, sir, to watch your surgeries and your presentation. Over to you, sir, for big bubble DALK, how to get it consistently.
Do you hear me now?
Yes, sir, you're audible, sir.
Okay, thank you for the kind introduction. Actually, I'm supposed to be the last one to talk because the DALK is last but not the least solution for dealing with keratoconus. And actually, my topic is how to get the big bubble consistently, the secrets of success. The steps of big bubble DALK: centration, partial thickness definition, big bubble formation, stromal dissection, brave slash, cutting the remaining stromal flaps by right and left corner scissors, donor stripping, and finally suturing. Of course, the big bubble formation is a key step in the operation, and with success of this step, the whole operation will be easy. You should know some basics when you are doing big bubble DALK. You should know how to get the big bubble consistently, not one time and few times. No, you should have to know how to get it consistently. You should know how to differentiate between type 1 and type 2 big bubbles. And you should know how to perform a paracentesis safely and how to perform a big bubble roof to open it safely, the brave slash. And you have to be aware of some tricky situations like the collapsing big bubble and the premature opening of bubble roof. And finally, you should master the technique of manual DALK in the case you want to convert from big bubble to manual DALK. So I will concentrate my talk today on how to get the big bubble consistently, because when I'm attending a lot of meetings, most of surgeons are asking me, what are the secrets beyond your technique that you show us you have a great success rate in your cases? So the big question, as I have mentioned, is how to get the big bubble consistently. The secret of success is we should inject air very deep, because you want to inject near your target. Your target is a descent membrane. So you have to inject very deep near this membrane to have the bubble from the first injection. So to achieve this, you should do a very deep partial thickness terrification. And of course, since you are injecting very deep, you should use a blunt cannula, not a needle. And you should know where to place your blunt cannula exactly. You should place it very deep in the terrifying groove. Very simple instruments. You should have a crescent knife, insulin needle, a rounded spatula, 27 gauge, blunt cannula, 27 gauge also, and a 5cc syringe. Very, very basic instruments. So this is, I will show now my personal technique or my personal tips. You go to the cornea, and at site of terrification, you take different pachymetry readings. And then you choose the thinnest pachymetry. This is the first safety margin because you don't want to penetrate through the globe. You want to make a partial thickness definition. So you have to base your calculations according to the thinnest pachymetry. This is the first safety margin. Not only this, you should take only 80% of this thinnest pachymetry. This is another second safety margin to avoid unintentional perforation during terrification. And I want to emphasize that the corneal thickness at site, at center, has no role at all in our calculations. What is important is the corneal thickness at site of terrification. When you get the number of the thinnest, 80% of the thinnest pachymetry, if you are using adjustable terrifying, you go and put the number you have chosen on your adjustable terrifying. But if you are using the non-adjustable terrifiers, we all know that each quarter then cuts 60 micron stroma to get, so we divide the number of the thickness by 60. This will give you the number of terrifying turns you're supposed to do in such a particular case. So if you are using adjustable terrifying, you go directly and put the number. And if you are using, for example, the baron terrifying, you should calculate how many quarter turn I'm supposed to do in this particular case. So we go applying the thickness using, this is a more adjustable terrifying, putting the terrifying and rotating the terrifying until it stops by itself. And you should have this deep terrification. This is a very important. You should have very deep part thickness. You should this look very deep. This is our aim, to be as deep as you can. So how much deep I am in this case, but this of course based on calculations. It's not haphazardly. And then you define the deepest part of the groove by crescent knife. The role of the crescent knife is just make a mark. This small mark define the deepest part of the terrifying groove. And then you go to start making the first half millimeter of your tunnel by sharp insulin needle, half millimeter only. You go by the insulin needle parallel to the iris, just half millimeter to start the tunnel. And then you introduce the 27 gauge rounded spatula. It is a blunt, so you can go very deep in the stroma. And you go further in the stroma, paracentral. And then the final step, you go with the 27 gauge cannula attached to 5cc syringe, and you advance it slightly further in the stroma, and you inject. You will find you will be having the big bubble immediately with no emphysema from the first injection. I will repeat the same technique again.
After making deep terrification, we open the groove widely and then retract the peripheral rim and make mark at the deepest part of the groove by crescent knife, just a mark. And then we start our tunnel, the first half millimeter by sharp insulin needle parallel to the iris, and then we introduce blunt spatula, as you see, very deep in the stroma, and then we introduce the 27 gauge blunt cannula. I'm using Donald Stan's cannula, the same track, and we advance it further ahead to have tight stroma, and then we inject air. We'll be having a transparent bubble immediately, as you see.
It is always a reproducible technique. So most of us know that when you get the bubble, either from the first time or after repeated injection, you always have a lot of emphysema, a lot of air going here and there, like this example. We call this white big bubble. You see, this a lot of air coming circumferential and making, of course, we have the bubble, but still a lot of air. So this is emphysema because you are injecting not so deep. If you are not injecting deep, the air has to go through the whole cornea until it reaches this membrane and make bubble. So I call this the opaque or white big bubbles. But if we look again to my personal technique, I will do it again. You open the groove widely, you retract the peripheral rim, you define the deepest part. You start your first half millimeter by insulin needle, and then you make the tunnel with blunt spatula, and then you go by a blunt cannula attached to 5cc syringe and make a forcible injection. You will be having now what I will call it transparent big bubble. You see, there is no emphysema. It's just transparent big bubble. I will show you too many examples of this. This example, when you inject in the deep plane, you will be having the bubble immediately, as you see. I call this no opaque big bubble. You see, these are different examples, and the technique is always reproducible because you are injecting very near this membrane. So there is no time for the air to go there and there. It just pushes this membrane and get the bubble immediately in a transparent configuration, as you see. Of course, not our aim to have these transparent bubbles, but this support the theory that the injection of air very deep is very important of getting the bubble. Another 3 example, look carefully, it will start immediately, you see, because you are injecting very deep. And this also, you see, there is no emphysema whatsoever. And the last example, there was some resistance in big bubble enlargement, so you can stop injecting and make paracentesis to lower the aqueous pressure, and then go again and have your big bubble safely, what we call it the transparent, no opaque big bubble, as you see. In conclusion, the immediate formation of the big bubble without any stromal emphysema supports my point of view of the importance of injecting air very deep near desmoid membrane. Big bubble formation is a key step in any DALK operation, and we should spare no effort to obtain the big bubble consistently. I know that DALK is the last option of treating keratoconus, and most of the surgeons are afraid to go to the DALK because of the unfamiliarity with the big bubble technique. I hope that this demonstration of how to get the bubble consistently will help them to face the last option of keratoconus management, which is DALK. Thank you.
Thank you, sir. Really beautiful videos to watch. And I must say, it's easier said than done. You have said that it's easy to achieve it consistently. We all know, all cornea surgeons, that that's not the case. But one point I found very beautifully highlighted, that the intrastromal cavitation bubbles that sort of appear if you're superficial, the emphysema, that will not appear if you are deeper. So that for me is a very good learning point today. And any tips when you have an in small bubble which does not reach till the periphery? Of course, if we follow your technique to the point, I don't think that's an issue that often, but sometimes we do end up, especially the beginner surgeons, with a smaller bubble that has not reached up to your refined margin. So any tips for that?
Yes, I have already shown one, the last case. When you have some resistance of enlarging the big bubble, you have to keep injecting more and more. And if you still have resistance, I have learned this from Rajesh Fogla. He stopped doing injection, do paracentesis to lower the tension in the anterior chamber, and go again and inject. You will find your bubble will enlarge to reach the proper size.
Yes, Rishi, you would want to say something on the technique, of course. You also have your peel and groove technique, which you've
Yes,
taught all of us.
the pioneer of manual DALK.
Always a pleasure to enjoy to see your big bubble videos. It's just
Thank you.
amazing how you do it after case. Just wanted to ask you, when you're at that depth, how can you avoid getting a type 1 bubble?
No, I think
which
the incidence
the
of
type.
to have type 1 or type 2 bubble, in my opinion, has no relation to the depth of injection. The occurrence of type 2 bubbles, I think it occurs in the cases with, for example, corneal scarring, when the dual layer is scarred and attached to the stroma, so there is no place for the air to go except behind the dual layer. And in some dystrophy, for example, like macular dystrophy, the incidence of type 2 bubbles are also more. So I think there is no relation between the depth of injection and the type of bubble. All these were type 1 big bubbles, and I was injecting very, very deep.
So if you do have a type 2 big bubble, Dr. Katamish, would you, what are of course, the chances are that, chances of perforation are
Yes,
more.
yes.
Would you take any precautions, or how would you do it differently,
Yes.
if you have a type 1 big bubble?
Yes, this is a very good question, Namrata. Of course, we don't advise anyone to expose type 2 bubble because the desmoid membrane is very fragile and it ruptures on the slightest trauma. So my technique now, when I get the big bubble type 2, I forgot about this bubble and I continue my case as a manual DALK. So I forgot that I have a bubble and I go doing manual DALK, and after I reach the proper plane, I just punctured the big bubble type 2. So I have at the past I was exposing big bubble type 2, but I have a lot of troubles rupturing the desmoid membrane. But now I ignore it completely, do manual DALK, and just puncture the bubble.
There was a very interesting presentation by Dr. Bussen at Keratocon last, in which to be able to be at the right deep depth, he was actually creating a small
Puncture, yes.
perforation in the periphery,
Intentional puncture.
and then go just anterior to that to be sure that he was just ahead of the Duaz layer.
This is a very, very odd thinking, in my opinion, very strange. But there is no need to make a puncture. You saw all my videos. You can reach a very deep plane without needing to have a puncture. Just calculate the thickness at site of terfination. Take the thinnest location, 80%. It's not necessary to be just a few macron from this membrane. Just 60 macron, 70 macron, we leave 20% safety margin. So I think there is no need to make an intentional puncture to have to know the proper depth.
Also, suppose it's a type 2 bubble which is coming from one side, but it does not come right up to the edge on the other side, then you can maybe do AC paracentesis, which is equivalent to a perforation only, and then subsequently not allow that type 2 bubble from one side to actually go right up to the periphery. But of course, if the whole thing is very fast, then you can't control it.
Yes, of course, yes. There is what I call it the expansion of big bubble type 2, especially big bubble type 2, the plane is between DUA and desmet, and the plane there is no adhesion. So once you open by paracentesis, the aqueous pressure gets lower and the bubble expands tremendously. This phenomena couldn't be with type 1. Type 1 is 8.5 millimeter and it cannot expand because of the strong attachment of dual layer at the stroma, that side.
Okay. Tushar, you would want to ask something?
I have a question if...
Yes, Vishal.
Hi, sorry, I'm joining late.
Tushar, we can't hear you. You have to, I think, the volume of the speakers have to increase.
No, I mean, we can let Vishal sir go ahead first, ma'am, and then I'll...
No, Tushar, please go ahead. I can wait.
No, I would just lovely talk, and it's always really nice to see sir's videos.
Thank
No
you.
particular questions in this case.
All right. So, Dr. Katamish, hi, Vishal Janji here. We met briefly at AIOS. So, while I missed the initial slide, but I've seen your videos, of course, they're fantastic. My question is sort of more generic. So the quest towards achieving a big bubble and thereby bearing the decimates, it has been going on since I was a resident in India, which is now nearly 20 years. What do you think you gain if you bear the decimates as opposed to when you do not bear the decimates. There are only a few studies that have shown that if you leave anything close to 80 microns stroma, without having to struggle to bear the decimates, the patient will be fine. The visual quality is going to be okay. The reason I'm asking you this question is I've worked in places where you cannot get a corneal tissue for 2 years to do a optical transplantation. Now I work in the United States where the tissue is available in 6 hours. But I do think when I go and present and tell people, keep on trying to get the big bubble. But the most common question that I get is that I can't afford to try to get a big bubble because I have a tissue that is suitable for lamellar transplant. And if I cannot get a big bubble, there's a perforation, then I have to convert to a PK. So I've tried to convince people to try and get a big bubble, but I also think that I feel defeated now because I have to stop pushing people to sort of try and get a big bubble and unfortunately have a perforation, and then you need a good quality tissue. So I guess my extended question is, how many big bubbles do you think a beginner, a fellowship trained cornea person needs to achieve consistently to be more confident? Because that's one of the most common questions when we sit in instruction courses. I can't get a big bubble. What do you suggest? How many cases should I do?
Thank you for your comments. I agree on what you said, but I disagree with you that with the other surgeons thinking that doing big bubble, and if it fails, I should convert to BKB. Why? When you are doing big bubbles, for example, too many injections and you just have emphysema only, I don't have bubble, you can convert to making manual dissection, which may be easier even from if you have a predetermined decision. So I don't agree on the concept of trying to have the bubble will end with me to convert him to PKB. No, it is if you have the bubble, it's okay. If you don't have it, you can manage as a manual DALK layer by layer dissection. This one point. The second point is I think I don't know if you watched my video from the start or not.
No, I didn't. I'm sorry, I joined a bit late.
No, because I have shown my personal technique, which is very, very, very reproducible. And I think the problem of don't having the bubble, it is a lack of some knowledge of the technique of getting the bubble. My point of view is you should have your injection very deep. So you should make all the steps necessary to have deep injection. For example, I know some surgeons are doing standard terifynation for every case, just 4/4 turns. No, I make a proper terifynation according to each patient. I go to the site of terifynation, I measure the bachymetry, take the thinnest bachymetry, then take 80%. So you should first of all do a deep terifynation. And then you should also, sometimes doctors doing deep terifynation and to inject in the middle of the groove. Doesn't make sense that you have this effort to do this deep terifynation and to inject superficially. So my second point is you have to inject very deep. So I think if these tips or basics are clear in the beginner's DALK surgeon, it will help them a lot of achieving the big bubbles. For myself, my success rate now for the keratoconus cases almost 99%. But this is the straightforward keratoconus cases with stromal scarring. But for the corneal scarring, of course, the success is less. But for the straightforward keratoconus cases, the success rate is very high. Not because I am a talented surgeon, because I have some concept of how to inject air, how to use the blunt cannula, and how to reach a very deep terifynation. All these basics will help the young surgeon to have a very good success rate. This is my opinion.
Thank you. Very good.
Second, laser has an important role to kind of reach the right depth, and of course, intraoperative OCT.
If you have intraop OCT, then you know exactly that you are 80%. So
yes, of course, Dr. Namrata has a great experience in doing DALK with intraoperative OCT. Of course, it will help us. But even if you don't have this expensive tool, you can do it without any help of this.
Yeah, Dr. Namta, I've operated with Massimo as well in his OR. He also thinks, I think this is basically, it comes from what Dr. Katamish says, old school thinking, but understanding the concepts of the anatomy that
Yes, exactly.
he doesn't have an intraporosity and he thinks that it's a very expensive tool and he doesn't need it. But I have to say that for the beginner surgeons who are just starting their cornea practices, having access to intraporosity maybe gives them a little bit of extra confidence to try more things. That does help, especially if they are not able to achieve big bubble, they are doing layer by layer. It does help them.
So
Yes,
Vishal, even for expert surgeons, even for us, it gives a big,
yes, of
Yes,
course.
it is a
yeah.
big
So
tool.
so we keep on dissecting if you don't have the big bubble, and the surgery becomes lengthy, of course. And then you're very careful. You don't want to perforate what you have because you are. I would say you care enough for the patient, or you're greedy for yourself that you don't want to perforate after so much hard work. So intraporosity does give you some
Yes,
picture. You have an idea. Okay, well, I think
yes,
I'm
of
less
course.
than 100 microns away. I'll stop dissecting now. So
Also,
Yes,
it,
especially in healed hydrops, when you're trying to do a manual DALK, then you exactly know where your scar is, and there you can, go anteriorly rather than going towards the scar. You can change the direction of your dissection a little anteriorly and then complete the dissection.
yes, I
yeah,
agree that anti-operative ST is a very important tool, but there is it's not an excuse for the
Yeah,
who doesn't have it in the operating room
exactly.
that I will not do that. No, it's not excuse to not work without it. But if you have it, it's a great advantage, of course.
absolutely.
I think we'll move on to the next talk. Dr. Vishal Janji, sir, we'll have you talking about the newest diagnostics in keratoconus.
Thank you. I have to confess that some of the slides are something that some of you have seen during the Bangalore meeting, but I hope this will make sense. Can you see my slides?
Yes, sir.
Okay, okay. So this is basically a very basic talk about diagnostics of keratoconus. I wish I could have gone before Dr. Katamish. Um, so I'm just going to talk about some of the practical applications of corneal topography and biomechanics. This is a very old topic now. Um, I started working in biomechanics in year 2009, 2010. And when it was really new, everybody was sort of doing ORAs, and we had only one machine to have an idea, give us a rough idea about what corneal biomechanics is. But I guess the popularity of collagen cross-linking did make our lives easier, because that, in fact, made us think about corneal biomechanics even deeper, to get a better understanding of what it actually means. So corneal mapping in general, we all like it when it's objective. You don't want to just look at a scan nowadays without any numbers. So you want really any kind of corneal map to give you objective information. It has to be repeatable, easy to perform. Most of the current devices are now easy to perform. The capturing is easy and they are easy to understand as well, without all those complex, algorithms and numbers that used to come in our hands about 10 years ago. And of course, I do use some of these maps, whatever maps they are, including biomechanics, to discuss with the patients. And patients do appreciate if they can understand what is happening. So Placido disc is still a very sort of commonly discussed technique, not used technique. It does give. We still have pictures of Placido discs in our clinics. We show the patients how a normal cornea is made up of these concentric rings optically, and in keratoconus that gets distorted. Um, when again during my fellowship, I think the most commonly used technique was to capture the interior surface of the cornea and video keratography. We still have one VKG here in the United States in our clinic, believe it or not. It gave us a very good picture of what happens on the interior surface of the cornea. And again, this is basically a sort of glorified Placido disc with numbers, of course. So by this time, everybody had a good idea of how the cornea looks in terms of its K values, in terms of its thickness. So having a machine that gives us exact numbers or close to exact numbers of steepness of the cornea, it gives you a good idea of if the patient has any ectasia or even abnormal cornea. But of course, this is not really enough, because you cannot tell, or you cannot pick most of the patients until they are really late in the disease. So scanning slit devices started measuring the posterior surface of the cornea. It didn't take us long. If you look at the literature, one of the first papers comparing scanning slit and VKG, it dates back to 1990s, where basically it was established that if you are trying to capture early ectasia, you have to look at the posterior surface of the cornea. Anterior surface is, of course, OBSCAN 2, which is one of the most which was one of the most commonly used slit scanning devices. It captures both anterior and posterior surface of the cornea. But we all know that in advanced ectasia, the repeatability of OBSCAN, it is not great as compared to the currently available devices. Pretty much in sort of late 2000s, we started using Scheimpflug devices. One of the most commonly used devices, the initial device with one Scheimpflug camera, was Pentacam from Wetzlar, Germany. So basically, you have a device that can very accurately measure the central and peripheral cornea, anterior and posterior cornea, over a good diameter of at least 9 to 10 millimeters. And it will give you comprehensive indices. The most commonly used index was the Bellin-Ambrosio index. It's still very commonly used in most of the refractive clinics and cornea clinics when you're following up with the patients. The cone in keratoconus, because we are talking about ectasia here, it can be of various types. You can see how a Scheimpflug device, and it doesn't have to be Pentacam, any Scheimpflug device will give you a very comprehensive, a very pictographical appearance, results of any ectasia that appears on the anterior or posterior part of the cornea. You can have an early bow tie or a displaced cone. And inferior cone, of course, is the most commonly seen picture in keratoconus. You can have a large central cone, or you can have keratoglobus. And of course, it can also pick up specific ectatic diseases such as pellucid marginal degeneration. So for Pentacam users, we know that it's not very difficult to sort of diagnose or distinguish between keratoconus and normal corneas. You can use certain indices. As I said, the BAD is still very commonly used. And if you are looking at a keratoconus suspect compared to a normal cornea, you will see that becomes a little challenging, especially with all the indices that are available on the Pentacam. The Pentacam users or Pentacam manufacturers, I would say, they still recommend that we use ISV, IHA to differentiate between suspect and normal corneas. BAD sort of becomes less useful when it comes to distinguishing between suspect and normal corneas, and that's where the holy grail really lies. You can use Scheimpflug devices, specifically Pentacam here, to monitor the progression of the disease. The ABCD nomogram established by Michael Bellin is now incorporated into the Pentacam. Most of the Pentacam devices, I have to confess, I don't use it that often. Everybody has their own little sort of nomogram to follow up their patients, but ABCD is useful. You need more than one reading, of course, to use any program, any software that monitors progression of the disease. Now, going back to our initial discussion about diagnosis, we always wonder if we are diagnosing these patients early enough. This is a patient who has a normal looking swept source OCT with corneal thickness, which is close to 590 microns. And the inbuilt ectasia screening program, which is present in many devices nowadays, that shows us that the patient actually has 0% chance of having corneal ectasia when you look at this scan. And this is the pentacam, which shows relatively normal. If you look at the D score, that is within normal limits as well. But when you look at the other eye of this patient, you can see the patient has full-blown keratoconus. So basically the other eye now, the first eye, is labeled as form first, or as Renato would say, this is VAE, which is very asymmetric ectasia, when you have large amount of ectasia in one eye and the other eye is nearly normal or form first. This is another patient where the D score is normal, and you see the other eye. This is the right eye and this is the left eye. Basically, again, showing that unilateral keratoconus does exist, although it's a matter of a conflict here, whether the right eye is perfectly normal or has any signs of keratoconus, and that's where corneal biomechanics comes into place. Non-tomographic diagnosis is now becoming more common. Unfortunately, not many people have access to Corvus, or when they do have access, they are not able to use it in clinical practice because the number of cases that you have with form first is actually not very high. So when we look at biomechanical properties, we are basically trying to apply the use of or the measurement of corneal biomechanics to not only diagnose keratoconus or corneal ectasia, but to understand the pathogenesis of corneal ectasia. How is it possible that a cornea that becomes anatomically ectatic actually is ectatic before the changes are actually picked up on advanced diagnostic platforms such as Scheimpflug devices. So to measure biomechanical properties, the two devices that are commonly available, I would say, although Brillon is becoming more available as well, is ORA and Corvus, and we do have access to Corvus here, which is basically an ultra high speed Scheimpflug device which measures a corneal deformation response to a puff of air. That's how it looks like. It works like an NCT device. So basically a puff of air indents the cornea and sort of the cornea springs back into action. And in between this indentation and springing back into normal position, thousands of measurements are made. We did show many years ago that Corvus, the repeatability is actually quite good in normal as well as in keratoconus eyes. The newer generation Corvus actually has two important indices built in. One of them is the CBI, or Corvus Biomechanical Index. This is derived, although we don't need to go into details, but I really want to mention this. This is derived from an inbuilt software which uses a random forest plot AI, utilizing the deformation amplitude ratio, which means when you throw a puff of air, you have to measure how much how much deformation amplitude actually happens when the cornea is indented with a puff of air. It also uses a specific stiffness parameter, which is basically a separate presentation. So CBI is now inbuilt into Corvus. Basically, if you have a CBI index of more than 0.5, that cornea is labeled as suspicious. Scheimpflug devices, specific Scheimpflug device, which is Pentacam, measures the PAD, and we are all familiar with that. It actually combines the data that is derived from Pentacam with the data that is derived from the Corvus device and combines that to sort of produce another index called TBI, or tomographical biomechanical index. It is important to realize that it is not a simple addition of BAD plus CBI that gives us the TBI. So it is not uncommon for us to find a patient where the CBI value is abnormal, but TBI is still on the borderline and a BAD is abnormal. So TBI is an additional index that is described or produced on the Corvus device. Going back to this previous patient that I showed initially, who had normal cornea and other cornea, the other eye was full-blown keratoconus. So you can see this is the same picture I showed earlier with normal BAD score. When you do when you run a Corvus, you can actually see the CBI is actually abnormal, and the TBI is abnormal as well. So thereby telling us, as I mentioned earlier, that there is something which is more important than the anatomical changes that are picked up by Scheimpflug devices. So this is a video that it's an old video now, about 2 years, but I still like to show it because I use it to discuss with fellows and with patients as well. So basically, it shows how the indentation that is caused by that puff of air on corvus changes before and after cross-linking. And this video, it's not available on all the corvus devices. So we have an upgraded version. I'm sure other countries have that as well. So if you look at this, the indentation is more before cross-linking, which is signified by the blue line, and it decreases after cross-linking, which is represented here by the pink line. So again, another way to show that cross-linking actually helps in improving the biomechanical properties. So to conclude, the newer diagnostics actually help us to pick up form thrust keratoconus. You can use it for refractive surgery screening. It becomes difficult to use these devices for refractive surgery screening because most people will actually say that, well, my patient has a normal pentacam, so I'm not going to run corvus on this patient. So what we have started doing in our clinical practice is we only use corvus in refractive surgery clinic or refractive surgery patients when they do not have a normal pentacam or they have a bent borderline pentacam. You can pick up cases for collagen cross-linking. I don't use it to look at the progression of the disease, but I do look at corvus when I have to decide on repeat collagen cross-linking in these patients. And of course, this is something which we can hope in future that this will allow us to test the efficacy of various treatment modalities as we go forward in future. Thank you very much for your attention.
Thank you, sir, for a very comprehensive overview of the recent tomographical and biomechanical diagnostics. What is your view on stromal mapping and epithelial mapping in ectasias?
So we have epithelial mapping. We've stopped using it now. It does epithelial mapping. What we've noticed is it relies a lot on the surface disease. We get a lot of false positives. It is very difficult for us, at least, and this might be just our practice, to find patients with corneal ectasia who have absolutely normal tear film, and it doesn't interfere with capturing of epithelial mapping. Another thing that I've seen is, although epithelial mapping is quite repeatable, we have a device called OptoView. OptoView is now acquired by VisionX, and the device is actually called Avanti, AVNTI. It's quite repeatable, but the problem is when a patient who's progressing on pentacam, for example, and we want to see if there are changes in epithelial mapping, the progression basically on epithelial mapping, it does not corroborate with the progression that we see on pentacam. So not very convinced with epithelial mapping so far. I don't have access to stromal mapping. What do you mean when you ask about stromal mapping? What device are you talking about?
MS39 and the collagen lamellae arrangement and the stromal architecture is increasingly being investigated for its potential role in being a predictor of ectasia, even if the other parameters do not point towards ectasia.
Sure. No, it's a fantastic idea. A lot of work is going on. One of the things that we are hoping will see the light of the day is optical coherence elastography, OCE. You see, the whole point of picking up early disease is that you are able to pick it up before you are able to pick up any structural changes. So when you talk about structural changes, that's something that is already visible. So the idea of collagen cross-linking and a step before collagen cross-linking is that it improves the biomechanics of the eye, if that is even true. Okay. I'm not 100% sold on the idea of biomechanics, but I'm definitely sold on the idea of non-tomographic progression, which is picking up the disease before it actually shows up on pentacam. And all of us have, I'm sure we've seen enough keratoconus patients where you actually see progression happening in front of your eyes. So one thing that I did not discuss, and again, it's a separate talk, is to measure the optical quality using devices that are currently available. One of the first devices was OCUS, Optical Quality Analysis System, which actually picks up how the modulation transfer factor, or MTF, changes in patients with keratoconus, even in early form of the disease. So, a lot needs to be done, if that answers your question to a certain extent.
True. Namrata ma'am, may I have your views on stromal mapping and its role in detection of preclinical ectasia?
I think although we have not really studied to that level, but it does play an important role. And because epithelium, does mask certain features which should be otherwise mapped out. But having said this, maybe we are digging too much into it, because ultimately, if you see physiologically, the epithelium is going to be there, whether hyperplastic or otherwise, you can't control that. So we also have to see in terms of physiology, but then yes, I think it may have a role to play as far as the progression is concerned.
Manpreet, am I audible?
Yes, sir. Yes, sir.
Yeah. Actually, hi Vishal, it was a fantastic talk actually. And I also initially used to feel and used to, read a few articles that the epithelial thickness corresponds with the, reduction in the stromal thickness, and is the area which is thinner, it's weaker, the epithelium is also thinner. But after evaluating a lot of these maps, what I found out that epithelial thickness map does not exactly corresponds with the stromal thickness map. And that is why I was still wondering that whether I'm not understanding it properly or something like that, because I used to feel that the stromal thickness, the area where the stromal thickness is least, should have thin epithelium. But it's not the case when I have evaluated a lot of MS39 maps and all those. So that's what, when I heard you talking about that, that epithelial thickness may not be totally reliable. I was also wondering when I evaluated those maps.
I think Dr. Rishi Swaroop is going to answer our questions.
Our next talk is on
Yes.
role of epithelial maps in diagnosing ectasia. I invite Dr. Rishi Swaroop, sir, for this talk.
Sure.
Sir, please.
Rishi, my apologies in advance.
We have laid out the groundwork for you, sir. You have a lot of
Go ahead.
questions.
No, I'm just joking. It's please.
But before we get started on the talk, I think I'm not completely denying what you have to say, Dr. Vishal, that for following up of progression, it may not be a great tool, but I think it's a great adjunct to the diagnosis of pre-topographic ectasia, especially for LASIK screening. I think it has a very important role there. And just like posterior elevation maps help us to pick up early ectasia, I think it does have a role. And it may not be a diagnostic tool or a prognosis or a follow-up tool, but I think it certainly has a role in preventing us from taking up many of these patients for corneal refractive surgery.
Also, Rishi, when you do customized triple ablation and you do the maps with the
Yes.
MS39,
Yes,
it plays an important role
yes, you
because
can
it dissociates epithelial thickness from stromal thickness and allows you to ablate at that point where it needs to be ablated. So I think there, for customized ablation or focal ablation, whatever you want to
Yes.
call it,
Yeah.
it plays an important.
Even for the planning how much to ablate, you will get an exact idea of how much your transepithelial is going to ablate the epithelium in that area. So
Yeah.
you can do all of that.
I completely agree with that.
Yes, Rishi.
So I'll just get started with my talk. So the topic that I've been given is epithelial thickness maps in ectasias. So for many of the people who may not be familiar, epithelium is not homogeneous over the Bowman's membrane, and basically, if your stroma or the Bowman's membrane is irregular, the epithelium will become thinner or thicker in the area, so that the ultimate surface of the cornea becomes as smooth as possible to be able to give us a good interface for refraction of light. And it kind of compensates for the irregularities in the cornea, like you're seeing in this OCT image. The stroma is a bit ectatic, and in that area, the overlying epithelium thins out to compensate. So till some point, it thins out and compensates, and at some point when it cannot thin out further, that's when you start seeing the changes on the topography. And that is the premise of using epithelial thickness maps to kind of pick up pre-topographic ectasia. So normal thickness of the corneal epithelium is somewhere around the range of 50-55 microns. And although it's pretty much uniform, but it is slightly thicker centrally, followed by inferiorly, then superiorly, and then nasally, then temporally. And this is what is the point we were discussing, that over the area of the maximum disease in ectasia, where the stroma is bulging, the epithelium thins out to compensate, and around the area of that thinned out epithelium, you may have a thickened donut of epithelium, because the epithelium is constantly coming from the limbus but is not able to climb this mountain. So it kind of collects at the base, and that's essentially where you also see the Fleischer's ring. So one point I'd like to make here is very often you will see that the area of your ectasia on the topography is larger than the area of the thinning on the epithelial thickness map. And that, I think, is because the thickened epithelium also around the base of the cone also kind of compensates to that topographic change. So very often, if you look at the patterns carefully, if you add up the area of the thinning plus the thickening, the donut of thickening, that is what shows up as the red on your topography. So this was the landmark publication from Randstein and his group, which showed the use of high-frequency ultrasound to measure epithelial thickness map. So this was the original tool that they had used, and this is how they had shown that they used to call it Artemis at the time, I think. And different grades of keratoconus, he demonstrated very nicely. Thinned out epithelium surrounded by a donut of thickened epithelium, which is exactly what we are seeing nowadays. But I think this particular machine didn't really become a commercial success. But OCT, the concept of using OCT for measuring the epithelial thickness maps was shown by Dr. David Huang's group. And as the resolution of the OCTs have become better and better, we are getting more and more accurate maps, larger diameter maps, which give us a lot of information about what's happening with the epithelium. And I think we're just at the tip of the iceberg of what all this can be used for. I'm sure there'll be more applications of this data that we're getting, and probably AI will help even more in understanding what to do with all this data that we're getting from these maps. So this is what I wanted to show you. See, this is the area of the thinning is smaller that you can see on the map on the right, the epithelial thickness map. The middle one is the pachymetry map, and you can see the area of topography is showing a little more bulge on the sides, and that probably is because of the donut of thickened epithelium around that area of thinning, which is also contributing to the bulge in the stroma on the topography. So this is one case. You can see that there's a little bit of asymmetry in the topography. One could possibly think this is a corneal warpage. The pachymetry looks great. But if you look at the epithelial thickness map, there's a distinct thinning of epithelium surrounded by a donut of thickening. And sure enough, if you look at this fellow eye, it's a clear-cut case of keratoconus. And in fact, if you see the epithelial thinning in this fellow eye is slightly lesser, but you can see the thickening around is more. I think one more very important utility of the epithelial thickness maps is to look at warpage. So especially patients who are coming in for corneal refractive surgery, And our traditional teaching is wait 1 or 2 weeks of free from contact lenses before you do a corneal refractive surgery. But if you have a epithelial thickness map which is perfectly smooth and uniform, you don't really need to wait, and if the topography is not showing you any changes. So I think also it helps you to differentiate early ectasias or any suspected ectasia from a warpage very, very easily. You will get a thickening of the epithelium in a warpage, whereas you'll get a thinning of the epithelium at the suspected site in a case of ectasia. So this is just to show the maps in different grades of ectasia, and you can see the parameters which the machines give, like minimal epithelial thickness and difference between the maximum and minimum. So various parameters can be studied, and we'll come to that. So various machines, most of the anterior segment OCT machines now have the options of epithelial thickness maps in them. And this was alluded to by the previous speaker, Dr. Janji. Avanti is the machine he uses, and there lots of the newer devices have got these large diameter maps, which can give us information of the peripheral cornea also very nicely. The original machine from OptoView, which was the RTView, had only 6 mm maps. So there you would miss out some of the peripheral information, which is now there in the newer machines. And MS39, of course, gives you everything in one, even the topography, elevation maps, all in one. I think it's a very good tool to have in your clinic. So this is pretty much a normal case. You can see everything is in the cool normal colors, and in contrast, this is a case of ectasia. You can see pachymetry map shows focal thinning inferotemporally in both the eyes, and correspondingly, there is area of focal thinning of the epithelium surrounded by a donut of thickened epithelium around it. So I've also been, I do epithelial thickness maps for all my patients who are going for refractive surgery. And of course, all the diagnosed cases of ectasia. And I feel that it is consistently giving very predictable patterns in almost every case. You will see the epithelial changes. If you look carefully, I think it's a very, very useful tool, and it certainly has a role in our practice, especially if you're doing corneal refractive surgery. So we've done this little study in our hospital of 40 normal versus 40 keratoconic eyes, and we studied the epithelial thickness maps, and we studied all these parameters: central epithelial thickness, inferotemporal, superotemporal, different quadrants, then difference between the thinnest point versus the ratio with the diagonally opposite point, the difference between the maximum and the minimum epithelial thickness, etc., as is shown. And we've basically taken these by putting the cursor manually in the different sites. Of course, we found that these were the parameters which were statistically significant: the central epithelial thickness, in terms of difference between normal and keratoconic eyes, and the inferotemporal area, minimal epithelial thickness, maximum epithelial thickness, and the ratio between the thinnest point and the diagonally opposite point on the map. Similarly, ratio between the thickest and the diagonally opposite point, and the difference between the maximum and minimum. So just to show you some of the cases. And based on this, using the statistical analysis, these were the cutoff values that were suggested. And when we looked at different cases, you can see most of the parameters were abnormal. And in the milder cases, you would have at least some of these parameters that were abnormal. So this, again, you can see this is a very kind of formiferous, kind of a very mild ectasia, but the minimal epithelial thickness was abnormal. So I think this is a useful tool. I don't have this machine, but it's frightfully expensive. But those who do have it, I think it's like the perfect tool for imaging keratoconus, and gives you your curvature maps, pachymetry maps, epithelial thickness maps, elevation maps, everything in one, and that too with large diameter maps. So to conclude, OCT is a useful adjunctive tool in the screening for corneal refractive surgery and for diagnosis of early ectasias. Both maps are useful, and it's important to correlate these maps with what is happening on the topographic maps. And if everything is lining up, then you're probably looking at something suspicious. And large diameter maps, of course, are useful. So the newer machines which can give you large diameter maps are useful, especially for peripheral ectasias like pellucid. Thank you.
Thank you, Dr. Rishi. I think you have laid most of our doubts to rest. Namrata ma'am, now I would like your opinion. Now we have all the information. Now what's the opinion of the house?
So after Rishi's taught us about epithelial maps, it becomes easier to conclude. So I think in times to come, it is going to play a very important role. And like Rishi said, maybe not for we have so many other tools for diagnosis of keratoconus as such, but I think in refractive surgery, it plays a very important role. And we have been using it in refractive surgery to rule out, especially, when you want to refuse a patient and you really don't know patient is borderline, and then you always look at the epithelial maps. But like I said, in customized ablation also, there are machines now, excimer lasers, which have been linked to this, and they help in customized ablation, especially when you have to do very minimal amount of ablation and only ablation which is there at the cone. So I think it is here to stay. It is only going to epithelial correlation of the epithelial maps is only going to get better and better in the times to come.
Yeah. No, Rishi, fantastic talk. A lot of therapeutic. So that's the difference between biomechanics and epithelium. Epithelial mapping also has a therapeutic use. Biomechanics does not as of today. One of the other things that, Rishi, I don't know if you're aware, Topcon came up with this concept about 10 years ago. They were doing Bowman's mapping, which was supposed to help in sort of diagnosis of keratoconus. I think Abhijit, who works with Rohit, he started working on Bowman's mapping as well. But I don't think that led to any place where it can be used in clinical practice. But that's another thing that might be useful in therapeutics as well, especially finding a role for Bowman's layer transplantation. It'll be good to have sort of teasing of all the layers separately, epithelium, Bowman's, and stroma, and looking at them individually.
I think, sir, you were talking about the Narayan Nitrale team, Bowman's
Yeah,
one.
yeah.
Yeah, I
Abhijit
also
does
have
that.
heard the talk. I think they have,
and they were subtracting the epithelial map from the topography and basically your Bowman's topography.
Yeah, yeah.
So they have posted some interesting results also, I think, on the role of the collagen fibers models and the Bowman's, etc. But of course, it's experimental as of now. Clinically, how much application it will have, I think we'll know with the years to come.
Yeah. Well, as Dr. Namrata Inishi said, we don't need to dig too much into it for now.
Don't need to, because keratoconus is keratoconus. So
I know.
You have to look at the whole thing compositely. Can go to the next talk, Manpreet.
Yes, sir. Yes, ma'am. We have Dr. Rajesh Sinha, sir, who will be talking about intrastromal lenticule and collagen cross-linking in keratoconus. Over to you, sir.
Thank you, Manpreet. At the outset, I would like to thank AIOS for this opportunity. Is it there?
Yes, sir. Yes,
okay.
Sir. Your slides are visible.
So I'll be talking about just about a little bit about our results of stromal augmentation with negative meniscus donor lenticule. So the basic idea was when I started it, I think maybe 6 years back. Sorry. Initially when we had cornea which was less than 400 microns, it was difficult to do cross-linking. And plus, some of these patients, they kept on progressing, required DALK, etc. So then this idea came that if we can augment the stroma by, additive keratoplasty, that may increase the thickness of the cornea, and it will also have a positive impact in the sense that you are in a position to do cross-linking, isosmolar cross-linking in these patients. And that was the basic idea when we started doing it. And with the negative meniscus, the basic idea was to have a thinner central lenticule and a thicker peripheral lenticule in order to have an arc shortening effect, so that it can cause some degree of flattening and some degree of regularity of the surface. So we selected patients of less than 400 microns, and then we created an intrastromal pocket with femtosecond laser, and riboflavin was injected into the pocket, and negative meniscus lenticule implantation was done with accelerated cross-linking. We gave this terminology PHILAC, which has been sent for publication, and it's been accepted. The patients above 18 years were selected. Patients who were having a thickness of 320 to 400 microns. The reason was this, that you want the lenticule implantation is done at a level of 150 microns, and you want 150 microns below that as well, in order to have a good support. And patients who were very happy with the contact lens, some of these patients who are even having a thickness of, say, 250 microns, using minuscule contact lens with very good vision, scarring, etc. Some of these patients I'm following up, and they don't want anything. So we cannot do anything in such cases. And of course, in corneas, which have cone size less than 6 millimeters, it is helpful. Otherwise, it can cause even deterioration of the elevation pattern. So we used microkeratome to create a 200 micron lenticule, and initially we used this is how it is done. So after creating the lenticule, we just dry it up, ablate the central 4 millimeters with the excimer laser. So it's a simple method of creating a negative meniscus lenticule, and then it is soaked in riboflavin, and then it is implanted intrastromally. So initially, when we started, we used the Visomax system to create the pocket. In that, we could create a pocket of 7.8 millimeters. And so we were using a 7 millimeter lenticule. So this is the pocket created, and the riboflavin as it is there, it is spread all around, and in most of these cases, some of these cases, they worsened actually. And what we found out that this part of the peripheral part, the thicker part, was coming over the cone in some of these cases. So we wanted to have a bigger pocket, and we started using the FS200, wherein we can create a 9 millimeter pocket, and an 8.5 millimeter lenticule can be implanted, so that it can cover up nicely a cone of up to 6 millimeters. The central part can take care of that. And this is how the pocket is created, and it is dissected as shown in the earlier videos as well. And then the lenticule is introduced into the pocket, and it is easy to introduce, and you can easily spread it from inside as well as by tapping from outside. Then you put riboflavin, and in some of these cases, I have started putting one suture. Initially, I used to keep it sutureless. Now I'm putting a suture just to see whether the suture can have an additive effect in terms of that arc shortening effect of this negative meniscus lenticule. I don't know at this point of time. Maybe time will tell. Once I analyze the data. Post-operatively, we give topical antibiotic, steroid, lubricant. What I would like to emphasize here is that initially, when we just thought that we are putting a lenticule in intrastromally, and we just require, it's like a simple procedure. We just require a topical steroid for 6 weeks to 8 weeks time. In some of these cases, the haze persisted, and in some of these cases, the haze came back, and it was quite significant in late post-op period. And then we started using topical steroid for a longer period, at least for 6 months, and maybe up to 1 year, so that you can have a clear lenticule. Because there's always a tendency, the biggest problem in this technique is that you have two interfaces, and wherein you can have haze. So this is how it looks like on day one. It's a thick one, but as the time advances, in 6 months period, the thickness of the lenticule reduces, the cornea becomes clearer, it looks better with time, and a little bit flattening as well. So this is how it looks like if you use topical steroid on a long-term basis, and there's hardly any interface haze. Here in this part, you can see a little bit of haze is there with an 8, but this was the initial 7 millimeters lenticule with an 8.5 millimeter lenticule. You hardly get to see anything, but it is a little unpredictable in the sense that some of these patients do have a little bit of haze, but in one of the interfaces. But then all these patients have to be managed with mini scleral contact lens, and it works well in these cases. Just show a few maps. This is one patient who had a K1, K2 of 53.9 and 59.2 with a Kmax of 65.4. And 6 months after the lenticle implantation, the K1, K2 reduced to 52 and 53.7, and the Kmax was 56.1. This was a very good response, and the cornea became quite reasonably regular, and the patient had a good visual improvement with contact lens. Another case with a K1, K2 value of 52.7 and 56.6 with a Kmax of 58.4, and 6 months after the implantation, it became 49.2 and 50.2, which is very much acceptable one after astigmatism, and Kmax of 55. So in some of these cases, another eye of the same patient, 53.9 and 9.2, and it reduced down to 54.3 and 55, which was a very significant reduction in astigmatism. But you may not get the same in all the cases, because sometimes you tend to have it is what I have felt after doing initially in some of the cases wherein I had very good results. I was very optimistic and very happy, I would say euphoric about it. But then it does have a little bit of unpredictability in terms of the topographic change. But the basic idea is to reduce the astigmatism. The basic idea is to increase the tectonic strength. The basic idea is to, with cross-linking, you can, strengthen the cornea. You can increase the thickness of the cornea so that you can defer DALK as long as possible. And all these patients do require mini scleral contact lens for visual rehabilitation. This is the results. And all the patients who have been rehabilitated with mini scleral contact lenses, they are doing quite well and have a very good visual outcome. The only thing which I am always worried, and I'm always very careful, is the interface haze, because you have two interfaces and the risk of interface haze is definitely there. Rarely infection, but yes, in one of the cases in the previous set of patients, the patient had infection, and then I had to explant that, remove it, and later on the patient would require a DALK. And in cases wherein sometimes your selection is not proper and it's a very large cone, in such cases you can have aggravation of corneal irregularity as well. So you have to have a patient with a reasonably central cone and a cone which is less than 6 millimeters, and definitely not more than that. Rejection, I have yet to see any. So in conclusion, this technique provides good tectonic strength to the cornea in case of keratoconus, which definitely is needed in such eyes. It increases thickness. We do cross-linking in order to have this idea that it will restrict progression, and it has worked to a great extent in a large number of cases, not in 100%. But yes, in a large number of patients, it causes a reduction in keratometry by that arc shortening effect, and that we have seen again in a majority. It does defer the need for keratoplasty, but we have to remember it's a tectonic process, a tectonic procedure, and it also improves the irregularity of the cornea so that we can have a good contact lens rehabilitation of these patients for a long term without the need of keratoplasty. It is not a refractive procedure at all. And as I said, it can best be visually rehabilitated with mini-scleral contact lenses, and we should avoid in very eccentric and large cones. So thank you very much for your patient listening.
Thank you, sir, for a very balanced overview of the procedure, highlighting both the pros and cons. I think next we have intrastromal implants by Dr. Praveen Vadavali. Maybe we can have a discussion after both the talks together.
Yeah.
Hey, hi everyone. So that was a very nice talk, Rajesh, about using a negative meniscus lenticule. So let's see if I can sort of put my point across from the point of view of using stromal collagen lenticules, this time made of porcine collagen for keratoconus. And I've titled my talk as how do you avoid keratoplasty for keratoconus by using this kind of lenticules. Now, having said that, there has been a surge either in the detection or in the number of patients with keratoconus who are coming to clinics worldwide, and this necessitates the investigation and probably identification of additional procedures that might be alternatives to keratoplasty. And I think in the last several years, ever since collagen cross-linking has made its appearance on the field, the relative number of LKs or DALKs or even PKs has come down quite significantly, or at least hasn't kept up with the increase in the number of keratoconus that we're seeing. So the typical kind of case that we would like to try this kind of implantation is not all keratoconus, because not all keratoconus is equal, but probably the ideal patient for whom this might be suitable is somebody who has very asymmetric keratoconus, good vision in one eye, and is unlikely to use a contact lens in the other eye. And typically, you would position this patient for a DALK, where you have a thin enough cornea, 355 microns, if you look at this topography, quite steep. So cross-linking doesn't have much of a role because you're not going to achieve much, and very unlikely that they'll use a contact lens because vision in the other eye is quite good as well. So in the typical algorithm for managing keratoconus, the patients for whom you would like to do PK or DALK are the ones where this procedure, where you have stromal implantation of lenticules, might be suitable. So if you sort of step back and think about what are the objectives you'd like to achieve by implanting a stromal lenticule within the cornea, you obviously would want to improve vision. You want to regularize the corneal curvature or induce significant amount of flattening. You would like to enhance the corneal thickness. If you want to follow up with maybe a topo-guided PRK procedure and a cross-linking as well, where these patients might not be suitable for cross-linking in the first instance. And because these lenticules can be cross-linked, or the cornea can be cross-linked as well, after the thickness is increased, you probably will help in preventing progression too. So you've seen one example of using stromal lenticules. There have been several case reports as well as case series of using different kinds of implants within the cornea. I think the first one was by Gerrit Melis's group, where they tried to position Bowman's layer transplantation to stabilize progressive keratoconus. And they found that there was stabilization, but did not seem to show a significant improvement in the visual acuity of these patients. And similarly, there have been decellularized lenticules, human constructs that have been implanted inside the stroma as well by Horjalio's group. And they too seem to have shown an improvement in visual acuity. But again, the visual acuity does not seem to be significantly improved, and probably is not compatible with spectacle vision. So we started looking at experiments in rabbits as well, and there have been reports of using smile lenticules as well in rabbits as a cross-species acceptance and as well as a xenotransplantation in some sense. And it seems as if they were relatively successful without inducing rejection. So in some sense, these are actually inlays, and the concept of inlays is not new. There have been synthetic inlays that have been used in the cornea for several years. In fact, more than 4 or 5 decades since inlays were first implanted inside the cornea. And most people did not have successful outcomes because these inlays tend to opacify with time. As you can see here, this is a 7-year-old synthetic inlay that is implanted inside the cornea of a normal patient, not a keratoconus patient. And this is a blind eye to study the biocompatibility of these implants. So it was at this time that we actually started working with this company called Gebauer Medical, based in Neuhausen in Germany. And we started using their microkeratomes to create dissect lenticules. And then the experimentation went on to see if we actually could use stromal implants in correcting patients who had hyperopia. And this is one such case, a patient with a +8 hyperopia, where we used a microkeratome fashioned corneal lenticule beneath the LASIK flap. So this was not to give biomechanical support, but to correct refractive error. And this seemed to be a successful approach, though the number of patients who would be suitable for this is quite limited. And I think I saw this particular patient whom we are operating right now last Tuesday, to be precise. And she's about 7 years follow-up, and she's still doing quite well. She has about +2 of hyperopia, but she's quite happy with the spectacles. And in the other eye, she required a clear lens extraction. So this does seem to be a viable procedure for correcting hyperopia at least. So following this, we also started experimenting with other procedures where we could implant these lenticules into a stromal pocket rather than under a flap. And at this point of time, Gebauer Medical started experimenting with porcine collagen as an alternative to human collagen to implant within the eye. And they came up with this product called Xenia. So this is a porcine collagen implant manufactured from porcine collagen and then decellularized to make it suitable to implant inside the eye. They're anywhere between 50 to 100 microns thick. Different variants actually had different thickness. Now they're around 30 to 50 microns thick, and they have been cross-linked multiple times with UV to also induce some amount of rigidity in them. Following this, they also are decellularized, and the extracellular matrix is also purified. And so because of this, it does not induce any immunological reactions at the eye. And why porcine collagen? Because there's been quite a few instances of using porcine collagen in human anatomy, including porcine cardiac valves, as well as ear cartilage replacement, meniscus and tendon replacement as well, basically in areas where there is eye vascular tissue. And so we thought that the cornea might be an ideal area to try using porcine collagen implants as well. So there has been previous reports of using porcine collagen for therapeutic keratoplasty, and like one of the first reports of xenografts for patients who had fungal corneal ulcer. In addition, it seems as if the porcine collagen amongst all xenocollagen is probably the most suitable because it has very similar characteristics to human collagen from the point of view of the collagen fibril diameter as well as the spacing. And that was the reason why the refractive index is also comparable, and that's the reason why porcine collagen was selected. So here is the same patient that we spoke about earlier. Good vision in one eye and poor vision in the second eye, and probably the ideal kind of candidate to undergo these kind of implants. So I'll just show you an animation of how this is done. So the stromal pocket can be either done using a femtosecond laser. For the first instances, we used the Visumax femtosecond laser to create a stromal pocket. Then later on, we tried to create manual pockets because we wanted to go deeper. And then we settled on the FS200 because it seems as if the pocket size was slightly larger, as well as the quality of the pocket was a little better with the FS200. So once you do that, you can inject this or you can just insert this into the pocket and position it. Earlier, we used to position it over the pupil, but now we are starting to position it over the center of the cone to achieve maximal flattening. Here is one example of such an implant. You can see the faint outline of the implant, and you can see that at 12 months post-op, there is some opacification, but the central area of the implant appears to be relatively clear. What was most impressive was the amount of flattening that was achieved by these implants. And if you look at the pre-op versus the post-op OCT, you can even eyeball the change in the corneal curvature. But I think this was most stark when we looked at the topography of these patients. So pre-op versus post-op, in some cases, we achieved close to 35 diopters of flattening in these corneas. And this is quite impressive because this almost regularized the curvature of somebody who would require a corneal transplant and did improve vision quite significantly as well. So in the first series of 5 patients that we operated then, we had relatively good success where the preoperative best-corrected visual acuity was anywhere between 2125 and 2250. All of them had very high refractive errors as well as very high cylinders. Post-op 3 months, the refractive error did reduce, and most of them had at least a 2-line improvement in vision. It seems as if the average vision was around 20/80 or so. The mean K also reduced on an average by about 22 diopters in these patients as well. There were a few patients who had a complication, and for example, this patient at baseline, again, a very thin cornea and relatively centered cone. But at post-op 3 months, she started to have a melt overlying the lenticule, and you see that it's only covered by epithelium. And we had to explant the lenticule in this patient. But what was gratifying was the fact that even after explantation, the corneal shape as well as the curvature regained what it was preoperatively. And this is pre-implantation and post-implantation with no change in the visual acuity. This patient was offered a DALK surgery, but then she did not want to get another surgery done at this point. So it seems as if, in some sense, even with the complication, it is sort of reversible. The lenticule that was taken out about 3 months later was completely acellular. There were no keratocytes that had invaded the lenticule, which probably might be desirable because keratocytes going into the lenticule might actually cause crenation of the edges and might also cause absorption of some of the collagen as well. Confocal microscopy showed activated keratocytes in the vicinity of the lenticule, and these activated keratocytes did not really go away even 1 year after the initial implantation. The lenticule itself was acellular and did not show any activity of the keratocytes, but the posterior surface of the lenticule also showed some striae in the posterior stroma and activated keratocytes here as well. One patient in whom we did a DALK after the lenticule was explanted did show some scarring in the vicinity where the stromal melt had occurred, and so this was as expected with no surprises. We expanded this series of patients to about 8 patients, and though a couple of patients withdrew from the initial study, most patients were relatively satisfied with their spectacle best-corrected visual acuity. They got up to 20/50 with spectacles, and it did not want to give them contact lenses at this point of time. Also, most of them had a significant improvement in the amount of preoperative spherical equivalent compared to postoperative. This is one example of a patient who was operated about 3.5 years ago. Preoperatively, she was about 2200, clear cornea, but too thin to cross-link, did not want a corneal transplant. The Xenia implant, as you can see on the right side picture, is 3 years later. She was 20/40 with glasses, and she was quite happy with the vision. And this is probably a prototype of the kind of outcome that you would like in patients. Same patient, post topography at 3 years' time, showing a relatively shallow implant, about 100 to 80 microns deep from the surface. And the flattening has been maintained over time as well. And in fact, this patient actually got more flattening that we bargained for and had flattening close to 40 diopters in some areas, so which is quite impressive. So, but then again, the question that was asked is why not use human collagen to achieve the same kind of result? The reasons are the fact that human collagen, the supply is limited. And even after the decellularization process with the same process that was used for the with the porcine collagen, it was still showing some antigenic load. And also because of the collagen that is similar in porcine and human eyes, we decided that we'll continue experimenting with porcine collagen. So we believe that with this kind of intervention with the porcine implant, it probably might have the same effect that cross-linking had on the numbers of corneal transplants in the past, where the number of LK, DALK, or PK actually started to drop in the last 10 years or so following the advent of cross-linking. So once this is a more mainstream procedure, we believe that this also will have a significant impact in reducing the number of corneal transplants that we need to do. So to sort of summarize, the Xenia porcine stromal lenticule implantation does improve corneal curvature and visual acuity. Seems to be a good option at this point of time for patients who are not suitable for collagen cross-linking, very thin corneas, and also has the potential to avoid the need for a corneal transplant. And we hope that it will become part of an algorithm to manage keratoconus in the not so distant future. Thank you very much for your attention.
Thank you, sir. I think we have covered the gamut of intrastromal lenticules now, both porcine and human. So I'll start with Rajesh, sir. Sir, you have used smile lenticule as well, I think initially when you were starting with intrastromal implantations, and then customized lenticule, the negative meniscus. Can you weigh in on the pros and cons of both?
Yeah, actually, when I started, the concept was using smile lenticule only, but then you need to have you have a very limited number of such thick lenticule available, because you want to have more and more cases with high refractive errors when you get a thicker lenticule. So then there were issues in that. And when you ablate the central part to make a negative meniscus, it becomes very thin. So finally, after initial couple of cases, I stopped using that, and then I started using the donor lenticule, wherein you can shape it as you want. You have I make a 200 microns and then ablate centrals 4 millimeters with 75 microns ablation with excimer laser, and then put it inside. So that's why a donor lenticule is more controllable, and you can use it anytime, and you have optimal thickness as well.
Also for the smile lenticules,
And the size as well.
You would need a regulatory approval because you are using some other patient, so you would need the consent of that patient, and you would need the serology of that patient also to be done, just like you do for human donor
Absolutely.
organs.
That's
Plus,
true.
Rajesh said size. We can't control the size.
Yeah.
I mean, we can control the size, but it's not as big as we would like it to be.
Yeah, initially when we started with a 7 millimeter lenticule, but in some of these cases it worsened actually. And then we had to increase, and that's why I shifted to FS200 instead of Visumax, and wherein I can create a 9 millimeter pocket, and an 8.5 millimeter lenticule is used now. So that way it is better than the previous set
So
of patients.
even classically for lamellar grafts, when you use for keratoconus, it is always best to go for a bigger graft than a smaller one.
Absolutely.
7.5 is not going to is not going to decrease the myopic astigmatism as much as 8.5 or 8. I mean, it should be, I feel it should be more than 8 by all means, but I would rather go for 8.5 or 9.
Absolutely.
One more sir, Dr. Praveen sir, in your presentation, I really found the confocal scan very interesting of the activated keratocytes just above the lenticule. Could they be contributing to the haze? Because in the clinical pictures, of course, we have not seen in real life your patients. The haze does seem to be more. So could they be contributing to the haze that is seen in the post-op pictures?
Yeah, I think most definitely there is haze in these patients after a few months of follow-up. Seems to start to appear at about 3 months and then tends to increase gradually. There are some patients who have more haze than the others, but we've maintained these patients on topical steroid fluoromethalone in most cases for the duration of the follow-up. It seems as if the haze is not present within the lenticule, but the haze is on the anterior surface and on the posterior surface of the implant. And it seems as if there is a cellular process that is causing a cycle of activation of keratocytes as well as some degree of apoptosis. And it seems as if these apoptotic keratocytes then get deposited as a fibrillar material on the surface of the lenticule. And that is what we found when we had explanted and looked at some of these artificial corneal lenticules that we had used many, many years ago. And it seems to be a similar process that is leading to the haze development.
I think a comparative evaluation of confocal microscopy just above the interface in both your set of cases, Dr. Rajesh and Dr. Praveen, would give very interesting insights if you could combine your data.
Yeah, Manpreet, actually,
Yeah,
we are
you
doing an ICMR study on this, wherein we are doing confocal microscopy in all these cases, and maybe we will be in a position to
No, but
tell
Rajesh, the thesis that we've done, I mean, not Xenia implants, but the implants that we had, we did compare
Yeah.
with the human donor cornea, with the set where Dr. Rajesh had used the donor lenticules vis-a-vis the biosynthetic implants that we were doing. But of course, we didn't do the confocal microscopy in that. But these human donor lenticules do have some amount of attrition, as is also shown by Rajesh in his series, that they do thin over a period of time, which doesn't have with synthetic implants, which is understandable that they are not going to undergo any attrition.
True.
So, ma'am, you have such a wide experience with biosynthetic corneas also. So, on a balance, are we moving towards biosynthetic, or eventually we have to find better ways to utilize human tissues only?
That's a million-dollar question. Human donor, I mean, that's you cannot completely do, you
Time will
cannot
tell.
completely, no, you can't do away, shouldn't say, but you can't bank on only synthetic implants. That is to say, they are there, and we don't have a track record which is, as long as human donor corneas is for any kind of corneal transplantation. So I think these innovations will keep happening till the point when we, have a complete corneal construct which is available to all of us.
I think the other important thought process is the regulatory one as well.
Yeah.
So if you have a company that is producing implants, they would prefer to use a non-human implant because from the regulatory approval, you probably are going to get approval as a device. And the laws that govern the regulatory approvals are different from when you implant a human lenticule inside another cornea, which is going to be governed by the eye-banking regulations, which are generally more difficult to circumvent, and also they tend to vary from country to country. In addition, if you have a product that is biosynthetic, you can potentially ship it across geographies as well. So it becomes easier for a company that is producing these. So very likely that industry will pursue something that is non-human. Whereas I think the onus is on the eye-banking community to probably try and explore a human implant rather than a synthetic one.
And porcine is something which everybody is, using because that's the only thing which is FDA approved. So all companies, they take porcine, the base is porcine for all of them to try out the synthetic implants. So
Sorry, ma'am.
Yeah.
Just to add, I think the future might be somewhere in between, Praveen, because I agree with you. some of the regulations, they consider these implants as devices, and we all know it's easier to get approvals when you're working on devices rather than tissue. Well, hopefully in the next 5 years, we'll have something, I don't know from where. We are trying to work on similar lines as well, on injecting stromal keratocytes into corneas for regeneration. Jorge Alio has published a few things on, adipose tissue derived stem cells. They seem to work. He's published about 2 or 3 papers now. We haven't tried those, but there's a paper published in Nature Communications last year showing the viability of injected corneal stromal keratocytes in animal eyes. So, so who knows, in the next few years, as I said, if we are able to find a way to construct the stroma from keratocytes and simply inject it, that might help us to circumvent the lack of availability of donor corneas worldwide, because you can have one set of keratocytes and multiply that and use it in multiple patients as well. So just something to think about.
I think we'll move to the next talk, Manpreet. Otherwise, we will keep sitting here till morning.
We'll have Keratoplasty in extreme ectasias by Professor Namrata Sharma, ma'am.
Okay, so thank you, Manpreet, for the introduction, and I would be talking to you about keratoplasty in extreme ectasias. We did have a talk by Dr. Farhad Afesi, who could not join, but he would be sending the recorded talk, and for the benefit of the delegates, we can circulate that recorded talk to everyone. As far as this talk is concerned, there are no financial or proprietary interests, and extreme corneal ectasias could be keratoconus with large cones, keratoconus with pellucid marginal degeneration, keratoglobus, pellucid marginal degeneration. Very important, even after surgeries, the post-PK and the RK keratectasia, where the thinning extends to the periphery, there's irregular astigmatism, and it is the advanced stages. So you can have both the central and the peripheral part of the cornea, which is ectatic, and what Professor Vajpayee has described, and which we all follow till today. And everybody, in fact, is stuck in lamellar keratoplasty, that is TILK, which is a single-stage technique of central lamellar graft with peripheral intralamellar tuck, and it acts tectonically and allows the optimal visual outcome, and also preserves the host limbal stem cells. So if it is a case of keratoglobus, this peripheral pocket is made all around. That means it is 360 degrees. The peripheral flange, is made all around, which is 360 degrees. And in the host, the pocket is made, and this is then fitted into the host. But if it is a pellucid marginal degeneration, then this flange is made only in the sector where thinning is there, and it is sectorally implanted or sectorally fixed into the pocket, which is partial. So this pictographic depiction, as well as the case, describes the technique. So we do a partial thickness trephination first, followed by the dissection, which is done anteriorly. And then the pocket is reinforced on all sides 360 degrees. And after doing this, the donor cornea is taken, is trephinated, and 0.5 millimeters of the frill is removed from the periphery. And this is then fixed onto the recipient bed after doing the paracentesis, so that the whole ectatic part of the cornea flattens, and the peripheral flange of the cornea is tucked into the pocket with the help of the sutures. And there is a trick to applying these sutures, and this is the way to do this. So these are some of the cases in profile, and also the front view to show how the ectatic part is taken care of, and the visual acuity is also quite good. Now, when it is just pellucid marginal degeneration, the flange is also made just in that sector where thinning is there, and the sutures are then applied. Again, the flange part is tucked into the pocket that was created earlier. This is the same case. Patient also had, now it's almost 10 years follow-up, also had cataract, so sutures are out, the cataract was also there, and then we did subsequently phacoemulsification surgery also, and patient has good visual acuity of 6/12 now in this eye. We've also done tuck-in lamellar keratoplasty for post-RK ectasias, and again, I think it is more difficult to do tuck-in lamellar keratoplasty in post-RK ectasias, mainly because the dissection becomes a little more difficult because there is no tensile strength of the cornea. So when you lamellarly dissect it, then it kind of gets difficult, but it is still possible to do it, and it does flatten this, and we did publish the results of our cases, which were 15 in number in Journal of Cataract and Refractive Surgery. Then there can be cases like this, post-RK and transverse keratotomy ectasia with healed eye drops, which can be seen. So this is bilateral patient which was operated elsewhere with radial keratotomy and transverse keratotomy, which can be seen here. And here the patient also had healed eye drops. So in this, again, the tuck-in lamellar keratoplasty was done. So again, partial thickness trephination is done, and notice that here the thinning is there right up to the periphery. So the pocket is being reinforced, and this is the part which is thinned out. So this peripheral flange is made accordingly. The Descemet's membrane is removed, and then this is subsequently placed onto the recipient bed, and this flange is tucked peripherally into the pocket that was created. And these sutures can be very difficult and can be very tricky. So one has to be careful while putting these sutures. So this is the patient, the pre-op from counting fingers improved to post-op 20/40 with adequate flattening. And this is the post-op pentacam, which shows that the flattening has occurred, although the corneal thickness is on the higher side, 570 plus, but the patient did have good visual acuity. And the keratometry K was 42.1 and 43.9 with the astigmatism of only 1.9 diopters. Now this is the other eye of the same patient, the left eye, which had a healed eye drops as well, and transverse keratotomy and radial keratotomy. So in this also, tuck-in lamellar keratoplasty was done, as can be seen here. And we went right up to the area of the healed eye drops, dissected a little anteriorly. And again, the patient did well with a visual acuity of 20/40 with adequate flattening. Now, apart from this, you can have ectasias such as this, although it is not a corneal ectasia because the pseudomembrane kind of a thing is there. But for such ectasias which are almost full thickness and with only more, you can say they're anterior staphylomas or adherent leucomas, which have actually, there has been a perforation, and the staphylomas is there, you would have to do large grafts in these cases. And the surgery again can be very tricky because a corneoscleral graft, which is very large, is used in these cases after removing all the membranes and all the remnants of the remnants of the iris which are there. And this is again a large anterior staphyloma for which a large sclerokeratoplasty has been done. The post-op regime has to be a little more aggressive with topical antibiotics, steroids, etc. And follow-up for all cases, whether ectasia or otherwise, one has to do again very rigorously. So for all ectasias which have large cones or which have peripheral ectasias, along with central ectasia, tuck-in lamellar keratoplasty is a very good technique. And as a single stage procedure, it gives not only the tectonic support, but also visually rehabilitates the patient. And in large anterior staphylomas, you may need to do sclerokeratoplasty. So thank you very much for your attention. And I take this opportunity to welcome all of you to Asia Pacific Academy of Ophthalmology with AIOS, which is going to be held in 2025, April 3rd to April 6th at Yashobhoomi, New Delhi. So hoping to see everyone there. Thank you.
Thank you, ma'am, for a very interesting talk. You have been the pioneer of DALK along with Dr. Vajpayee. So it's a treat to watch the surgeries. I would invite you, ma'am, for the closing remarks as well. We had a very fruitful session and we have run over, of course.
Tushar, I think some comments from you and then subsequently we close.
It was a lot of learning for me, ma'am. And I think when you're coordinating, is you pay the most attention. So it was a lot of learning for me. One of the things I think that is being talked about in the world is the advent of artificial intelligence, and I think possibly our shine flood tomographers, our OCT-based tomographers would probably be giving some amount of AI-based diagnosis and prediction as well in the future. So I think that's also something to watch out for in ectasias, ma'am.
Vishal, so I think we still don't understand corneal ectasia. I did my thesis in keratoconus when I was a postgraduate student, and I feel that that time we knew less, so we were more confident about whatever we did, and now we know more, so we are more unsure about whatever we do.
Yeah, no, I completely agree. It's that also, while I'm Dr. Namta's student, and of course Dr. Vajpayee's student as well. It's good to see that surgery stood the test of time. She learned it and then she taught me, and she's been doing it, and I'm doing it here. The excellent comment about knowing more, and but that's how science progresses. I really think that we will, as Praveen showed in his slide, we will slowly move away from having to need any kind of corneal transplant in keratoconus. If every single patient, imagine this, can be captured, well, not patient captured in person, but yes, the disease can be captured at a stage where you can do either cross-linking or a minimally invasive procedure, as Dr. Senha and Dr. Vadavali have shown. I think we will probably reduce the burden on the eye banks worldwide. So we keep learning.
So Dr. Tariq Atamish doesn't agree with us at all. And whatever you may do, even despite cross-linking, we have seen that, ectasia continues to progress in some of the cases. Whether it would have otherwise or not, we don't know. But
yeah. Sorry, so I have to say, I was talking about primary ectasias.
yeah.
Post-lentic ectasia, maybe we'll talk about it another time. It's a completely different pathology. So.
Okay, so thank you, I think, everyone, for being there. I know it's late in the night and we finished almost on time. We were given time till 9:40. I thought, how are we going to continue? But then the discussions were so vibrant that we could have continued more. And like I said, the more we know about keratoconus, the less we understand it. It's, like a thief. It every time escapes its complete problem where, you cannot completely find a solution. So thank you and good night.
If you could just get one picture with all the speakers' cameras turned on for
just pitched to say that you can now. Praveen is not there. Rajesh. So Praveen.
Okay. Cheese everybody.
One thing we have all learned is not documented is not done. So let's document it.
Done. Thank you so much.